So when we get past the brain and down into the spinal cord, we're talking about the pipeline between the control center in the central nervous system and the peripheral nervous system. So this is the link up, right? Sensory input from the body and motor commands from the brain move through the spinal cord. The motor commands are what we call descending information, and then the sensory commands are ascending information, right? The ascending information in the spinal cord generally comes from the dorsal and lateral sides, while the descending information generally comes down the ventral and lateral sides. Remember that the dorsal root from lab brings sensory information into the spinal cord, and those are afferent neurons, and the ventral root takes motor commands out from the spinal cord, and those are the efferent neurons. Okay, so those are the hookups to the peripheral nervous system. There are spinal reflexes that are also carried out at the level of the spinal cord that don't involve the brain, and these are stereotyped reactions to stimulus that are designed to ensure our survival. They're very primitive nerve pathways because they basically go from the stimulus to an afferent neuron to the spinal cord in the gray matter, and then to an efferent neuron, which is heading out from the spinal cord, to an effector, which is generally a muscle, right? And so it doesn't have many synapses in it, and so it's very fast, okay? Also, the cabling for a lot of these motor reflexes is the fast type of cabling. It's the nerve fibers that run at 250 miles an hour, right? Those are things like the hot stove reflex, where you put your hand on a painful stimulus and yank it away before you even realize what you did, okay? So those are all spinal cord functions. Now, the spinal cord runs from the foramen magnum all the way down to L2, where it tapers to a tip called the conus medullaris, and radiating out from that tip are a cluster of nerves called the cauda equina, which is Latin for horse's tail. And those nerve fibers serve structures in the hips and in the lower limbs, okay? There are enlargements in the spinal cord. The cervical enlargement are neurons that innervate the upper limbs, while the lumbar innervates the lower limbs, okay? Remember, the cervical means up near neck, right? And lumbar means in the lower back. You can see here with the spinal cord several important features, right? If we look here with the laser, right, you're going to notice at L2, right, the conus medullaris, and then extending down from that is the filum terminale. You can see that there in green, and that latches the spinal cord to the coccyx so that it doesn't bob up and down too much. And you'll also see radiating out from the lateral aspects of the spinal cord the denticulate ligaments, which are basically horizontal stabilizers, and they keep the cord from moving too much left and right. You'll notice that there are 31 sets of spinal nerves. They're all paired and they're all mixed, okay? And they're all named for the vertebrae that they are near, okay? C1 exits between the occipital bone and C1, right? C2 exits below C1, C3 below C2, right? So these guys are all on top, right? Whereas down here, when we get to C8, right? C8 is exiting below C7 and above T1, right? And then the remaining nerves are named for the vertebrae that they exit below, T1, T2, T3, and so on, okay? So again, the numbering is for the different vertebrae. So that's why you can have 8 cervical spinal nerves, but only 7 cervical vertebrae, right? Because you've got an extra one up here between the occipital bone and C1, okay? You can see the cauda equina radiating out and serving structures in the pelvic region and then the lower limbs, okay? Remember that a nerve is just a bundle of axons, all right? The afferent axons are bringing information into the central nervous system via the dorsal root, passing the dorsal root ganglion, and the efferent neurons are bringing information out of the central nervous system. The ventral root emerges from the spinal cord and fuses with the dorsal root and forms the mixed spinal nerves, okay? So you can see, again, the 31 pairs, right? The first letter of the spinal cord region to which it's attached, followed by a number, right? And those are the rootlets, right? The posterior root, which has the sensory neurons, and the posterior root ganglion. Sometimes these are called dorsal root and dorsal root ganglion. And the anterior or ventral root for the motor neuron, all right? And all of these are going to form mixed spinal nerves. So you can see those here, right? There's the dorsal root. There's the dorsal root ganglion. There's the mixed spinal nerve. There's the ventral root. And then it fuses with the dorsal root to form the spinal nerve. And then what happens as soon as the spinal nerve is formed is that we give off branches, okay? Some of these are communicating rami, and then some of these are dorsal and ventral rami. Dorsal rami wrap around to the back of the cord, and ventral rami wrap around to the front. And depending on where we are in the body, they will serve structures reasonably close to that level of the spinal cord, okay? You'll also notice that the spinal cord has white matter on the periphery and gray matter in the core, okay? This is the central canal filled with cerebrospinal fluid and lined with ependymal cells. And of course, the gray matter, we remember, is for signal processing, while the white matter is for signal transmission, right? The white matter are the myelinated axon tracts, and they get the information from one place to another. And the gray matter is to modify the electrical information before we send it on to its next location, okay? The spinal cord is protected by bone, meninges, and cerebrospinal fluid. So we've talked about the fact that the spinal cord is tethered by extensions of the pia, right, the filum terminale and the denticulate ligaments, but it's also surrounded from superficial to deep by three membranes, the dura mater, the arachnoid mater, and the pia mater, same as around the brain, okay? The vertebral column is what houses the spinal cord and meninges. The cord runs through the vertebral canal, and then spinal nerves exit through the intervertebral foramina, right? Those are the holes between the stacked vertebrae on the lateral side. And you'll remember that they're just big enough to let those nerves out, okay? So the meninges are shown here, right? The pia mater is the deepest meninge, and it clings to the cord itself and has a lot of blood vessels in it, okay? The denticulate ligaments are the lateral stabilizers, and the filum terminale is the vertical stabilizer, right? The arachnoid mater is above the pia mater, so it basically goes pia mater, then subarachnoid space filled with cerebrospinal fluid, and then arachnoid mater. And then above the arachnoid is the dura mater, which is a layer of dense irregular connective, which stabilizes the spinal cord. There's a subdural space between the dura and the arachnoid, and there's an epidural space between the dura and the vertebrae, okay? So you can see here in cross-section, this is the vertebrae, this is the body, this is the front, this is the back. Those are the transverse processes here and here, and that's the spinous process. There's the gray matter of the cord and central canal, right? There's the white matter on the outside, the dorsal root here and here, right? The ventral root here and here, the spinal nerve, okay? These are the communicating rami, and we'll get into those later. Those are features of the autonomic nervous system. And then we've got dorsal and ventral rami. Dorsal rami wrap around to the back of the cord, and ventral wrap around the front. They're not really shown here. They branch off of the spinal nerves. The epidural space is filled with fat. You can see that here, right? And then got the meningeal layers, right? You've got the dura on the outside, the arachnoid right underneath, the subarachnoid space there, and then the pia clinging to the cord. You've also got an anterior median sulcus, or anterior median fissure rather, and a dorsal median sulcus. Okay, the fissure is a deep groove and the sulcus is a shallow groove. And then you've got the ventral horns, the lateral horns, and the dorsal horns of the gray matter, and they all contain different neuron populations. Okay, so those are the meninges: dura, arachnoid, pia, clinging, right? Ventral roots, dorsal root ganglion. Those are the nerve cell bodies of the afferent neurons, right? And then you've got the communicating rami here, okay, and here, and then you've got dorsal rami and ventral rami, and a lot of those are not shown, right? And of course the gray matter and the white matter, okay? Sometimes we have to do a procedure called a lumbar puncture, in which we have to sample the cerebrospinal fluid in case it's infected. So what we do is pass a needle through the intervertebral discs and into the epidural space, through the dura mater, and into the subarachnoid space under the arachnoid mater, and withdraw some of that fluid to check and see if there are bacteria or viruses in it. This is a very serious procedure and a very serious condition if the CSF is infected, because as we've talked about before, the nervous system, the central nervous system, has very little immune defense, right? All they have are the microglia, right? Adult spinal cord is usually tested with lumbar puncture below L2, okay? Spinous process of L4 is at the highest point of the iliac crest, so that's to play it safe, right? We don't want to run the risk of touching the spinal cord with a needle, and that's why we have to go below L2, right, in order to sample some of the fluid without the potential for damaging the cord, okay? And unfortunately, you have to be awake for this procedure, and it's painful, okay? Now remember that gray matter we discussed was for signal processing, right? And those are the dendrites, the somas, and the unmyelinated axons of the neurons. Well, the white matter are the myelinated axons, and that's why we say that the gray matter is for signal processing, while the white matter is for signal transmission. The gray matter regions that we talked about earlier, the posterior, anterior, and lateral horns, right, all have different neuron populations. The posterior horns have sensory neurons and cell bodies of interneurons, and they receive and process sensory information. The ventral horns contain the motor neurons of the somatic motor division, which talk to skeletal muscle, and the lateral horns, which are only present in the thoracic and lumbar vertebrae, contain the neurons of the sympathetic division of the autonomic nervous system, okay? The gray commissure is a horizontal band of gray matter surrounding the central canal that connects the left and the right side of the gray matter of the spinal cord, and it contains unmyelinated axons connecting the left and right gray matter. And then we have nuclei, which are groups of cell bodies that perform a particular act, right? Remember, this is the third use of the word nuclei in this course. Nuclei of an atom contains the protons and neutrons. The nucleus of a cell contains the genetic material, and here nuclei of tissue are groups of cells that have a particular function in common, okay? Do they look different from the surrounding tissue? And the answer is no, usually, okay, with some exceptions. But they have particular tasks that they carry out, and they're located in a particular region, right? Somatosensory nuclei get signals from skin, muscle, and joints. Visceral sensory nuclei get signals from blood vessels and internal organs. Motor nuclei are going to innervate skeletal muscle, and then the autonomic nuclei are going to talk to everything but skeletal muscle, okay? So those are all basically collections of nerve cell bodies and dendrites that do those particular tasks. You can see here how we're organized, right? The different populations of neurons in different regions of the gray matter, right? So there are your interneurons receiving your afferent information, okay? And then In the lateral horn, we're going to have the autonomic efferents, okay? And then in the ventral horn, we're going to have the somatic motor efferents, right? So the dark red is talking to skeletal muscle. The orange is talking to everything but skeletal muscle, right? And then the incoming, right, the light blue is going to be the somatosensory information, okay, of which we are consciously aware of a percentage of that, right? Not a huge percentage, but some. And then the dark blue here is the visceral sensory information, and most of that we are unaware of, right? That is dealt with at the level of the hypothalamus and the brainstem primarily, okay? So we talked about the fact that a stimulus is just any physical change inside or outside the body, and it's the job of the nervous system to turn that into electrical information that the sensory nervous system can process and understand and then issue commands about, right? So most of that information is dealt with without our conscious awareness, and those are things like changes in the status of our blood pressure and our heart rate and other internal organs. Most of that we are unaware of, okay? The stuff that we are aware of is mostly somatosensory information, and it's only really a fraction of our somatosensory information that makes it to our conscious awareness by getting all the way to our cerebral cortex, right? So information has different speeds, and it gets dealt with by different regions of the central nervous system. White matter is going to be on the exterior of the spinal cord. Remember when we talked about the brain, the white matter was in the core of the brain. Here the white matter is on the outside, right? The posterior furunculus sits between the posterior gray horns and the posterior median sulcus and contains sensory tracts. The bundles are called fasciculi. Lateral funiculus sits on the lateral sides of the spinal cord, containing sensory and motor tracts. And the anterior furunculus sits between the anterior gray horns and anterior median fissure. The left and right anterior funiculi are connected by the white commissure, okay? And they contain sensory and motor tracts, okay? So basically, when we're looking at the spinal cord, all right, the stuff that's in blue is the stuff that is coming up, blue or violet here. And the stuff that's in red or orange is the stuff that's going down, okay? So this is why I said that most of the descending information is on the lateral and front of the spinal cord, and most of the ascending information is on the lateral and back of the spinal cord, okay? And notice that all of these different pathways are named for where they start and where they stop, okay? So for instance, if we look at the lateral spinal thalamic tract, okay? This tract over here is going to begin in the spinal cord and then end where? In the thalamus, right? And then from the thalamus, some of that information will make it to the cerebral cortex, right? The reticulospinal tract is a descending tract, and it starts in the reticular formation of the brainstem, and it ends in the spinal cord, okay? The vestibulospinal tract is going to start in the vestibular nuclei of the brainstem and is going to end in the spinal cord, okay? So that's how the tracts are named. You can always tell whether it's going up or going down because the first part of the name is the origin and the last part of the name is the end, right, the destination. You can see here different parts of the spinal cord, and what I want you to notice is that the lateral horns are only going to be evident in the thoracic and lumbar vertebrae. They vanish when we get to the cervical and the sacral vertebrae. They're no longer there, okay? And that's because those neurons are part of the thoracic division of the autonomic nervous system, which is part of the sympathetic division. And we'll talk about that when we get to the autonomic nervous system. Just for now, know That's a division of the nervous system that works without needing our conscious input, and it operates primarily when we're in fight or flight, meaning when we're in a panic situation, okay? And it is an efferent pathway of the nervous system. It is an outgoing pathway. Spinal pathways are either sensory or motor, right? Sensory pathways or afferent pathways are going to ascend towards the brain, and motor or efferent pathways descend from the brain, right? So motor pathways are dropping down, sensory pathways are going up, okay? Pathway characteristics, all pathways in the spinal cord are perfectly paired. So there's a left and a right tract. The axons are found in the spinal cord tracts, the myelinated portions, and the cell bodies are in ganglia, in the gray horns, and in the gray matter of the brain. Okay, not a surprise here. The spinal cord tracts, as a result, are the signal transmission part of the central nervous system in the spinal cord, right? While the horns are the processing parts, along with the cortical and the deep gray matter in the brain. Each pathway is made of a chain of 2 or more neurons, and most of them cross, they decussate, okay? They cross from left to right and right to left, specifically in regions below the neck, okay? Above the neck, some of the fibers cross, some of them don't, okay? But below the neck, they basically cross. And where do they cross? They cross either at the level that the information comes in, or they cross at the level of the medulla oblongata. Ventral pathways cross at what we know as the decussation of the pyramids, which is on the front of the medulla oblongata. Those are motor pathways. And the sensory pathways cross on the back side of the medulla oblongata, okay? So that's why we say that the right side of the brain controls the left half of the body, and vice versa, okay? Uncrossed pathways work on the ipsilateral or same side of the body, while cross pathways are going to be contralateral, okay? Sensory input is transmitted through spinal cord originating from general or special sensory receptors, okay? And there can be differences in receptor modality and receptor location, okay? Receptor modality is the type of stimulus that the receptor picks up. Tactile receptors pick up touch information, while proprioreceptors detect stretch and balance information in joints, muscles, and tendons, right? Visceral sensory receptors are going to pick up change in the status of an organ, okay? While somatosensory receptors are primarily the surface of the skin and the body's muscles and joints, okay? Somatosensory pathways carry signals from skin, muscles, and joints. Viscerosensory from our internal organs, all right? Now, again, as we talked about earlier, most of the information that we're consciously aware of comes from the somatosensory group, but even that, we don't get all of it, right? We just get some of it. The viscerosensory is mostly unconscious. It's dealt with by the hypothalamus in the brainstem. There are neurons that relay these signals to the brain and also bring commands down from the brain, right? So in the sensory pathway, we're doing an ascending pathway. We're working our way from the stimulus to the peripheral nerve to the spinal cord up to the brain. The first order neuron has a peripheral ending and a cell body in the dorsal root ganglion and an axon that leads to a secondary neuron. The secondary neuron is an interneuron and gets primary input and extends to a tertiary neuron or to the cerebellum. The tertiary neuron is an interneuron and receives secondary neuron input and extends to the somatosensory cortex of the parietal lobe of the cerebrum on the postcentral gyrus, which is that ridge of cortex that's right behind the central sulcus, okay, which is the border between the frontal and the parietal lobes, okay? The posterior furunculus has a pathway known as the medial lemniscal pathway. Signals that ascend here include proprioreceptive, touch, pressure, and vibration. There's a 3-neuron chain. The primary neuron relays the signal from the skin to the brainstem. The peripheral receptor has an axon and a spinal nerve, a posterior root, spinal cord, and then within the cord, the axon is in the posterior funiculus, and it's either the fasciculus cuneatus for information from the upper limbs and trunk, or the fasciculus gracilis from the hips and lower limbs. In the medulla, the axon contacts a secondary neuron, which relays the signal from the medulla to the thalamus, okay? And the cell body is either the cuneatus or the gracilis, right? The cuneatus is the trunk and upper limb information. The gracilis is the hip and lower limb. The axon decussates and joins the medial lemniscus. In the thalamus, the axon talks to a tertiary neuron that brings the signal to the primary somatosensory cortex on the postcentral gyrus in the parietal lobe. So you can see the wiring diagram here, okay? The neurons have been color-coded for you. So purple is your primary, right? So here comes primary, past dorsal root ganglion into the dorsal root, and then into the dorsal horn, and then up we go, okay? Up the spinal cord until we get to the medulla, right? And then we're going to pass through the pyramids, right? And then we're going to cross coming up, right? Told you that crossing over occurs at the level of the medulla in the back of the spinal cord, right? And then we're going to send that secondary neuron, this is the medial lemniscus, right? All the way up through the ventral side of the spinal cord, okay? And then all the way to the thalamus. And then the third order neuron takes it to the cortex, okay? So that right there is vibration, touch, balance, okay? Ascending information, okay? The anterior lateral pathway is located in the anterior and lateral columns of the spinal cord and responds to crude touch, pressure, pain, temperature, and it's another 3-neuron chain. The primary neuron relays the signal from the skin to spinal cord, and the axon is in a spinal nerve and a posterior root. The axon contacts a secondary neuron in the posterior horn, and then that secondary neuron is going to decussate and ascend in the contralateral white matter, either using the anterior or the lateral spinal thalamic tract. Okay, so again, starts in the spinal cord and is going to end where? The thalamus, right? The tertiary neuron in the thalamus is then going to relay the signal from the thalamus to the cerebral cortex, okay? And again, this is crude touch, pressure, pain, temperature, okay? So you can see this pathway here. So the first order neuron in purple, right? We cross immediately. We don't wait until we get to the medulla to do this, right? So we cross at the level that the information comes in. We ascend to the medulla, okay? And then we stay on that side all the way through the pons, brain, and into the thalamus. And then the third order neuron is going to carry it to the cortex, okay? So think of these as elevators, right? Elevators that can only carry certain types of passengers in certain directions. That's what this information is all about, okay? The spinocerebellar pathway, again, the name should tell you how it goes. It goes from the spinal cord to the cerebellum. Signals about proprioreception with a 2-neuron chain are moved here. The primary neuron relays the signal from the skin to the spinal cord. The axon's in a spinal nerve and posterior root. The axon contacts a secondary neuron in the spinal cord's posterior horn, and a secondary neuron relays the signal from the spinal cord to the cerebellum, okay? Some secondary neuron axons are going to cross, others remain ipsilateral, okay? So this is an important distinction, right? The ones that cross are decussating. They're moving from right to left or left to right. Some of them, though, don't, and they stay on the same side. And where are they going to end? They're going to end in the cerebellum, okay? So the axon is going to ascend either on the anterior or posterior spinal cerebellar tract, ending in the cerebellum. Now, why is this important? It's important because the cerebellum's job, one of its jobs anyway, is to serve as an on-the-fly movement editor in order for your motor commands to go to your muscles in a way that allows you to do meaningful movement, okay? So in order to do that, it has to have input from the motor cortex, which is in the frontal lobe. It has to have input from your eyes and your vestibular apparatus in the temporal lobe of your brain, which is getting information from the semicircular canals in the vestibule, which are part of your inner ear. And it also has to get information, proprioceptive information, from your muscles and joints, right? In order for it to compare the motor plan you intended to carry out with the motor plan you're actually doing, okay? So it's like checking if your commands are making it to the end result. And if they disagree, what will happen is that the cerebellum will correct that information and send it back up to the frontal lobe, and will repeat the process of sending that command down to the brainstem and the spinal cord and out to your skeletal muscle in order to correct your movement plan, okay? So there is your primary neuron, right? There's one from each side. Then the information will either cross or stay ipsilateral. Up will come to the medulla, right? Spinocerebellar pathway here on lateral side, goes all the way up to pons, and then is going to terminate in cerebellum, okay? So you can see that there in the arbor vitae of the cerebellum, okay? And this right here, you might remember, is the cerebral aqueduct in order to orient you. Remember that the cerebral aqueduct connects the fourth ventricle to the third ventricle, okay? Motor pathways are going the opposite direction. Motor pathways are heading down, okay? So they talk to skeletal muscle. So where do they begin? They begin in the frontal lobe of the brain, okay, in an area known as the premotor cortex, which is right in front of the precentral gyrus, which is right in front of the central sulcus, which is the posterior border of the frontal lobe of the brain. Okay, so that's where we form an idea of what we want to do. Then that moves from there to the precentral gyrus, okay? And then that plan is going to descend, right? The upper motor neuron is in the motor cortex, a cerebral nucleus or a brainstem nucleus, and then it's going to talk to a lower motor neuron, which is going to send axons out through the ventral root all the way to the target, okay? And that's going to tell the muscle to do its thing, okay? So you can see in the direct pathway, we have a route between the brain and the skeletal muscle. It begins with an upper motor neuron in the primary cortex. The axons run through the internal capsule, which passes between the lateral ventricles and the thalamus. And then it goes to the cerebral peduncles and then the corticospinal tracts and synapses with lower motor neurons in the anterior horn of the gray matter, which then sends axons out through the ventral root. That becomes the spinal nerve, and then those neurons will eventually make it all the way to their skeletal muscle targets, okay? It's called the direct pathway or pyramidal pathway because it crosses at the pyramids of the medulla oblongata, which are on the front of the brain stem, okay? The lateral cortical spinal tracts have an upper motor neuron that decussates within the medulla's pyramid. The axons form white tracts in the lateral funiculi and talk to lower motor neurons, which innervate limb muscles for skilled movement. While the anterior corticospinal tracts have upper motor neurons that form white tracts in the anterior funiculi. They decussate at the level of the spinal cord and then contact interneurons or lower motor neurons, which then innervate the axial skeletal muscles. So different place to cross, right? Lateral corticospinal tract crossing in the pyramid, anterior corticospinal crossing at the level at which the neuron goes out to talk to the muscle. So you can see it here, okay? Here we have the primary neuron in the cortex. Down we come, right? Through the midbrain, through the medulla, okay? And then we will hit gray matter, all right? And then we're going to exit through the ventral horn, okay? So here we come, we hit the interneuron, or we hit the efferent neuron. The ventral horn gives off axons that are part of the ventral root. Those fuse into the spinal nerve, and those go all the way to the skeletal muscle, okay? So some of these are going to cross in the medulla, okay? And some of these, like the anterior, are going to cross at the level of the spinal cord itself, okay? But in either case, we are crossing from left to right or right to left. That's why we say that the right hemisphere of the brain controls the left half of the body and vice versa. There are indirect pathways as well. The upper motor neuron originates in the brainstem, and the nuclei take a route to the spinal cord. In the lateral pathway, we regulate movements and tone in flexor limb muscles, which consist of rubrospinal tracts that originate in the red matter of the midbrain, okay? The red nuclei of the midbrain. And then in the medial pathway, we regulate muscle tone in movements of the head, the neck, the proximal limb, and the trunk. And that consists of reticulospinal tracts that run from the reticular formation to the spinal cord, tectospinal tracts that run from the midbrain to the spinal cord, and vestibulospinal tracts that run from the vestibular nuclei to the spinal cord, okay? So the reticulospinal tracts running from the reticular formation are important for reflexes related to posture and balance. The tectospinal are important in orienting response to visual and auditory stimuli, okay? Remember that we talked in the brain about the corpora quadrigemina, right? Those are 4 bumps on the back of the brainstem. The upper 2 are called the superior colliculi, and the lower 2 are called the inferior colliculi. And the superior colliculi are controlling components of visual reflexes, while the lower or inferior colliculi are controlling auditory reflexes. And they are located on the tectum of the midbrain, okay? And this is why their tectospinal tracts are important in allowing those responses to work, okay? The vestibulospinal tracts run from the vestibular nuclei of the brainstem and are also important in balance when you sit, stand, or when you walk, okay? Now, occasionally, the spinal cord will become injured, all right? Remember that the neurons in the central nervous system do not have the ability to grow and reproduce, with very few exceptions. So if you damage them, they are pretty much permanently damaged, okay? So one of the things that we try to do is use steroids after injury to help preserve muscle function by reducing inflammation. Steroids are anti-inflammatories, and by suppressing immune function, and I know this seems weird, by suppressing immune function, we can reduce damage to the nerve tissue, okay? Early antibiotics have reduced the number of deaths due to pulmonary and urinary infection, and we have recently been able to regenerate central nervous system axons using glial populations from the olfactory bulb, which is right above the ethmoid bone in the floor of the cranium, okay? There are apparently chemical signals in those glial cells that can induce spinal cord neurons to regrow. We have had at least one successful surgery in which we've restored spinal cord nerve function to someone who was paralyzed in a wheelchair for 4 years, okay? And that's because there's something in those glial cells that is a chemical cue to cause those neurons to regenerate, right? So that's at least one example of where we've actually fixed it using the central nervous system's own ability to induce growth and repair. We talked about the spinal nerves being mixed nerves, and I talked about branches that come off of those spinal nerves. They're called rami. This is just a branch. Posterior rami wrap around to the back of the spinal cord and serve structures in the posterior body wall. Anterior rami wrap around to the front and serve structures in the front. Okay, and depending on where they are, they might serve the arms, they might serve muscles between the ribs, they might serve structures in the hips and the lower limbs. Okay, and then there are nerve plexuses that are part of these anterior rami that are found in the cervical, brachial, lumbar, and sacral regions of the spinal cord. Okay, what is a plexus? It is a nerve net. Okay, a nerve net formed by the anastomosing and branching of nerve fibers, right? Anastomosing is where nerve fibers fuse together, okay? And branching is where they split. So what you make is this nerve net, and then off of these plexuses come ultimately peripheral nerves that serve structures lateral to the central nervous system, okay? Rami communicans are special branches that serve as on and off ramps for autonomic information, okay? They run between the spinal nerve and the sympathetic chain ganglion, which are in the thoracic and lumbar vertebrae, and these are connected to the vertebral column, okay? So you can see these different branches here. These are the communicating rami, and these are the ganglia, which are part of the sympathetic division of the autonomic nervous system, and we'll get more into that later. These are the dorsal rami, serving structures in the back, and then these are going to be ventral rami that are going to serve structures in the front. And where is the spinal nerve? It's this little short, teeny tiny thing right here, okay? So very, very, very short little thing, okay? Now, dermatomes are segments of skin that are supplied by a single spinal nerve. Some overlap in innervated regions. Examples include the T10 dermatome, which is a horizontal ring of skin around the umbilicus, and they can localize damage to one or more spinal nerves. An example, such as loss of sensation in the medial arm and forearm, indicates damage to the C8 dermatome, which is served by branches of spinal nerve C8, okay? They're involved in referred muscle pain, okay? We talked about the fact that with referred pain, the definition of that is that the pain, which you would normally think come from the location of the organ, is being moved to another location in the body, and that's because the pain leads from the organ and the pain leads from that part of the body, hit the spinal cord in the same spot and ascend in the same pathway and ring on the same pain line in the brain. And so the brain has difficulty separating the two, okay? You can see the dermatomes here, right? The dermatome indicates the area served by that spinal nerve, all right? And the idea, for instance, in surgery, if we're going to cut you, right, is you don't want to feel pain from the surgical incisions. So what they'll do is they'll numb the nerves that serve overlapping regions on these dermatomes so that you don't have any sensation. So an example would be, I had ACL surgery on both my left and my right knee. And when they did that, they had to numb dermatomes L2, 3, and 4, and 5 in order to actually work on the knee itself, okay, so that I don't have pain sensation and wake up during the surgery, right? Because these roots, while serving these regions, also overlap neighboring regions, Okay, so L4 is going to overlap L3 and L5. L3 is going to overlap L2 and L4, and so on. Okay, so they had to numb me quite a ways up. All right. Now, sometimes the setup of the nervous system is such that there are pathogens that can take advantage of the fact that nerve cells don't take up drugs very effectively. Okay, when we use drugs that operate on the nervous system, primarily they operate at the gap between the axon and its target. Okay, so they either increase the amount of time that the neurotransmitter spends in the synaptic cleft, or they reduce it. But they don't generally get inside the nerve cell and do anything. Okay, so viruses take advantage of that and mimic material that the nerve cells do take up, such as neurotransmitter. Okay, and what they'll do is they'll trick the nerve cells into using what's called retrograde transport to move their virus particles back from the axon terminal all the way back to the nerve cell body. Okay, in shingles, herpes zoster does this by sneaking into the axon terminals and using retrograde transport to get all the way back to the soma, and then it will reside inside the nucleus of the dorsal root ganglion until it decides to reemerge as an adult in a condition known as shingles. Okay, reactivated virus travels through sensory axons to the dermatome, generating rash and blisters as the viral particles emerge from the nerve ending. It's very painful. Okay, there are antiviral medications to reduce the severity, but they're not terribly effective. Okay, and again, the reason is that viruses don't use their own machinery to reproduce, they use ours. So anything that targets a virus's ability to reproduce can impede our own tissue's ability to reproduce. So we have to be very careful about how we design these drugs. There are vaccines to reduce the disease's severity. One of the most effective ways to deal with viral conditions is to vaccinate against them so that the immune system is already prepared for a second encounter with the viral antigen. And that way it doesn't get a chance to make you sick. Okay? But once the virus is home, once he's in you, it's really tough to get rid of it, right? Because he's literally in the cell. In some cases, his genetic material is integrated into our genetic material, and there's no way to get rid of that except to be able to do surgery on DNA, which may be something that we'll be able to do in the near future, but we can't do it right now. A nerve plexus is just a nerve net, right? Rami of nerves fuse and branch extensively, and we talked about the fact that we have these in the cervical, brachial, lumbar, and sacral plexuses. Most thoracic spinal nerves don't form plexuses, but instead have ventral rami that serve stuff in the intercostal region. Okay, the rami branch such that damage to one nerve or spinal segment doesn't deprive a muscle or skin region of all innervation. Okay, so that's sort of a safety precaution in the design of the body. The intercostal nerves are between the ribs, and those are the anterior rami from T1 through 11. T12 is a subcostal, which is under the rib. The T1 anterior ramus has a portion that goes to the brachial plexus and a portion that goes to the intercostal first space. T2 anterior innervates intercostals in the second intercostal space and gets sensory information from the axilla and the medial arm surface. And then T3 through T6 anterior rami are for intercostal muscles and get sensory signals from the anterior and lateral chest wall. T7 through 12, intercostal and abdominal muscles and sensory signals from the skin that overlie it. Okay. So there's an example of the ventral rami of the intercostals. Okay. Now, when we get into the nerve plexuses, which we will here in a bit, there's a law called Hilton's law that states that if a nerve talks to a muscle that crosses a joint, it also talks to the skin overlying that joint. Okay. And so that's one of the ways that you can remember what nerve talks to what muscles when we get to the sensory and motor map of the different nerve plexuses, which we will in a bit. The cervical plexus are the anterior rami from C1 through 4. Branches are going to talk to anterior neck muscles, the skin of the neck, and portions of the head and shoulders. But the rami from C3 through 5 talk to the phrenic nerve, which innervates the diaphragm, which is the main muscle of breathing. Okay, so that's the take-home nerve from the cervical plexus. And the way to remember the rami that talk to it are to remember the mnemonic C3, 4, 5, keep the diaphragm alive. Okay? If you damage the phrenic nerve, you can't innervate the diaphragm. It means you can't breathe unless you're on a ventilator. Okay? You can see here the branches, right? So you've got here 3, 4, 5, and there's phrenic nerve right there. Okay? So you've got nerve roots from all of those. Okay? There are other branches that serve stuff in the head and neck as well. Okay? And there are mnemonics that go with that. My main thrust here is that you remember the phrenic nerve in the cervical plexus. Okay? The brachial plexus are the anterior rami from C5 through T1. And these fibers extend laterally from the neck to the axilla, which remember is the area of your underarm. And they're made up of anterior rami, trunks divisions, and cords. Okay? So here we go with more stuff to memorize. All right? So from medial to lateral, the mnemonic is real tired, drink coffee now, which stands for rami, trunks, divisions, cords, and nerves. Okay? Rami unite to form trunks in the posterior triangle of the neck, the superior trunk from the rami of nerve C5 and 6, the middle from rami of C7, and the inferior from C8 and T1. And these divide into anterior and posterior divisions, which innervate anterior and posterior parts of the upper limbs. Okay? The cords are formed by in the posterior cord by the posterior divisions of the superior, middle, and inferior trunk, and contain portions of C5 through T1 nerve roots. A medial cord formed by the anterior division of the inferior trunk and contain portions of C8 through T1, and the lateral from the anterior division of the superior and middle trunk and contain portions of C5 through 7. Okay? All right. All right. So what are the nerves to know coming off the brachial plexus? They're axillary, median, musculocutaneous, radial, and ulnar. Okay? How to remember these? My aunt rammed my uncle. Okay? Okay? My aunt rammed my uncle. My aunt rammed my uncle. Okay? Axillary nerve is in the armpit, so it's talking to the deltoid and teres major and gets sensory input from that region. The median nerve runs between the radial nerve, which runs next to the radius, and the ulnar nerve that runs next to the ulna. Okay? And it gets sensory input from the palmar side of the hand and the dorsal tips of the fingers. Okay? With the exception of the little finger. Musculocutaneous is going to innervate the biceps brachii, okay, and get sensory input from the lateral forearm. The radial nerve is going to talk to the posterior arm muscles, such as the tricep and posterior forearm muscles, and get sensory input from the posterior arm and forearm of the dorsolateral hand. And the ulnar nerve talks to the anterior forearm muscles intrinsic hand muscles, and sensory input from the dorsal aspect of the two medial fingers. All right, so there are the roots, trunks, cords, divisions, and nerves. Okay, real tired, drink coffee now. Okay, so there are the nerves that come off, right? The take-home message, again, is to remember the key nerves, all right, and what they do. Now, how to do this? Well, there is a look at the different nerves, okay? And that's showing you, again, the location of some of these are easy, right? The location of the axillary nerve is going to be where? Up here by the armpit. That makes total sense, right? The ulnar nerve is right next to the ulna. The radial nerve is right next to the radius, right? And the median nerve is dead center between two of them, okay? And then you've got branches that serve the palm and the digits, all right? But what we're going to see in a bit is a sensory and a motor map of these, and that'll help you remember what nerve is doing what, okay? Brachial plexus can be injured. Frequently with sports, you can get a blow to the shoulder and you can tear some of those nerves, or you can produce pressure or inflammation, right? Axillary nerve injury can be the result of a compressed axilla or damaged neck if we break the humerus. What are we going to see? Problems abducting the arm and anesthesia along the superior lateral skin. Why? Because it's talking to the deltoid, right? Remember that the deltoid crosses the shoulder on the lateral side, the anterior, and the posterior side. So you can abduct the arm, you can flex the arm, you can extend and hyperextend the arm using the deltoid, okay? So if you take out motor commands of the deltoid, you lose some of that, okay? Radial nerve injury, humeral shaft fracture or injury to the lateral elbow, paralysis of extensor muscles of the forearm, wrist and fingers, and anesthesia along the posterior arm, forearm, and part of the hand, okay? Posterior cord injury can be caused by improper use of crutches, and that can hurt the axillary and the radial nerve, okay? The radius is on the thumb side of the forearm, okay? Median nerve injury, this is carpal tunnel syndrome. Paralysis of muscles in the fingers and anesthesia in portions of the hand. Ulnar nerve injury, you probably know this better as your funny bone, okay? Fractures or dislocations of the elbow causes paralysis of intrinsic hand muscles and sensory loss on the medial hand, okay? If you've ever hit your funny bone, you know that hum that goes down your medial forearm all the way to your little finger, okay? Superior trunk, injured by separation of the neck and shoulder. Any brachial plexus branch that has these nerves affected will suffer. An inferior trunk, if we excessively abduct the arm, so if you're standing in anatomical position, you bring your arm out to your side, right? But then above that, right? And then damage or tear those nerve roots, and that's going to hit brachial plexus nerve fibers as well. Okay. The lumbar plexus runs from the anterior rami of L1 through L4, okay? And that includes the femoral nerve, the obturator, okay? And there are some other important nerves as well. The ilioinguinal and iliohypogastric come off of there. The genitofemoral and the lateral femoral cutaneous, all right, are the other nerves that come off there. And the mnemonic to remember those is I twice go late on Fridays, okay? The femoral nerve is the main nerve in the posterior division of the plexus, and it innervates the anterior thigh muscle and the sartorius, and has sensory input from the anterior medial and inferior medial thigh and medial leg. The obturator innervates the medial thigh muscles and gets sensory input from superior medial skin of the thigh. And then there are other branches that innervate the abdominal wall and external genitalia. Okay, so here you see lumbar L1 through 5. Okay, and the different nerves, right? I twice go late on Friday. Okay, that's the way to remember it. Right? Okay. Here you can see anterior view. All right. Obturator nerve, you can tell because it runs through the obturator foramen. All right. The femoral nerve runs right next to the femur. Okay. The femoral cutaneous is lateral to the femoral nerve. Okay. And the genitofemoral nerve is going to go in towards the pelvic region. Don't sweat the iliohypogastric and the ilioinguinal. Okay. The sacral plexus. The mnemonic is cut fast through silly putty. Okay. And that stands for common fibular, tibial. Okay. And they become the sciatic. Okay. And then the pudendal. All right. The sciatic nerve is the longest and largest nerve in the body. It runs through the greater sciatic notch, and it's formed by portions of the anterior and posterior sacral plexus, and it's composed of the common fibular, that's the cut fast, and the tibial nerve. Okay, so the common fibular and the tibial fuse and become the sciatic, and then they split further down under the knee and become the common fibular and the tibial again. Okay, so it's an unusual nerve course. Okay, that's the tibial nerve. Innervates the hamstrings and the hamstring part of the adductor magnus, splits into the lateral and medial plantar nerves and talks to the bottom of the foot, and receives signals from the skin on the sole of the foot. Common fibular is going to run the lateral side of the leg, innervates the short head of the biceps femoris, and splits into the deep fibular and superficial fibular nerve. Okay, the deep fibular innervates the anterior leg muscles and muscles on the dorsum of the foot, and get sensory input from the skin between the dorsum of the first and second toes. And the superficial fibular innervates the lateral compartment muscles of the leg, such as the fibularis longus and fibularis brevis, okay, and get sensory input from the dorsal foot and anterior inferior leg. So there it is, right? So there is common fibular, right, coming in, right, and there is tibial, right, and then there's pudendal, right. Again, the main thing is to know the nerves and what they talk to, right? So here you can see the course of the nerve, right? There's sciatic, okay, and he's going to split into fibular, common fibular, and then tibial, right? And then pudendal is actually going to serve structures near the genital region, okay? So he's a short little guy. He comes off right up here, okay? All right, we talked earlier when we were looking at the coxal bone about the sciatic notch and a condition called sciatica, okay, which is a problem in people who are obese or pregnant, okay? The superior or inferior gluteal nerves can be poorly placed, gluteal injection injured, all right? They serve the gluteal group, right? The maximus, medius, the minimus. Sciatica is injury to the sciatic nerve, and we get pain down the posterior thigh and leg. It can be caused by a herniated intervertebral disc or by pressure on the nerve. A common fibular can be injured because of fracture of the neck or compression from a cast. It can cause paralysis of anterior and lateral leg muscles. The person will be unable to dorsiflex or evert the foot. Dorsiflex, again, lift the foot up with the heel still on the floor, evert the foot, turn the sole of the foot laterally outward, okay? Now, reflexes are rapid, programmed, involuntary responses of muscles or glands to a stimulus, which is required to start the reflex. The response is quick because there are very few neurons and very few synapses in these reflexes, and they're designed to increase our survival, so they have to happen rapidly, right? And their target in most of these cases is skeletal muscle, okay? A reflex is a survival mechanism. The response is always the same and is always involuntary, right? We respond to a damaging or a detrimental stimulus immediately, and we get the information about that later on. You can see the components of a reflex are here, right? You've got the receptor, right? And you have the afferent neuron, bring the information in. Then you have an interneuron, control center, and then we have the efferent neuron and the effector, which does the work, okay? Now, some of that nerve signal is going to go to the brain, but the brain doesn't have to be involved for the reflex to happen, okay? So this is a primitive pathway. These were probably some of the first nerve pathways to develop in evolution. There are different ways to classify spinal reflexes, right? If it's a spinal or a cranial reflex, we have to know the location. Is it in the spinal cord or brain in the reflex center, okay? So where is the control portion? A somatic or a visceral reflex talks to the effector, right? If it's a somatic reflex, the effector is always skeletal muscle. If it's a visceral reflex, it's something else. If it's a monosynaptic reflex, it has one synapse. If it's polysynaptic, it has more than one. It's an ipsilateral reflex if it's on the same side of the body as the stimulus, and a contralateral if it's on the opposite side. And then there's innate or acquired, right? Are you born with the reflex or do you develop it later on, right? You can learn reflexes as well, right? So there's some examples of different reflexes here, okay? Here you see the patellar tendon reflex, right? We take a reflex hammer, we hit the patellar tendon with the broad side of the hammer, and that stretches the patellar tendon. Stretch receptors pick that information up. They relay that information past the dorsal root ganglion to the dorsal root, and that's going to synapse on efferent nerve fibers that head out to the effector, which in this case are going to be the quadriceps femoris muscles, and what will happen is that the leg will go up. So this is a way to protect against excessive stretch of the muscle, right? And then we've got an example of a polysynaptic reflex, withdrawal from a painful stimulus combined with pushing away. Well, this is the withdrawal reflex here, okay? Withdrawal reflex, painful stimulus. The sensory receptor brings it in through the afferent neuron, past the dorsal root ganglion to dorsal root. Interneuron synapses on efferent neuron, and the effector, in this case, is going to be the biceps brachii and the brachialis, and we pull the arm away from the painful stimulus, okay? So those are fairly simple reflexes. Other reflexes, okay, include the stretch and the Golgi tendon reflexes that rely on proprioreceptors that are embedded, in the case of the Golgi tendon organ, in the muscle tendon, and in the case of the stretch reflex, they're actually embedded in muscle fibers in the muscle itself, okay? A muscle spindle is a proprioreceptor that detects stretch in a muscle, okay? And it has intrafusal fibers that are innervated by gamma motor neurons and wrapped in sensory neurons, and the fibers not within the spindle are extrafusal and are innervated by alpha motor neurons. So what's the difference between the two? Okay, the alphas are the motor neurons whose job it is to make the muscle contract, okay? So those are the ones that we became familiar with when we talked about muscle contraction. The gamma motor neurons are talking specifically to these receptors, okay? So when stretched, the spinal cord sensory axon fires impulses conducted to the spinal cord. reflexive contraction of the muscle after it's stretched as a result. The muscle spindle fires when stretched. The impulses go to the cord. In the cord, a sensory axon hits an alpha motor neuron in the same muscle, and it contracts. At the same time, the sensory neuron excites interneurons that inhibit motor neurons of the antagonist, and we get reciprocal inhibition, okay? So, for instance, in a patellar tendon reflex, right, we're stretching the quadriceps, right? So we send that information into the spinal cord through afferent neurons, and then we're going to send outgoing information. We're going to send contraction info to the quadriceps, and we're going to send inhibitory impulses to the hamstrings so that the leg will go up, you'll kick, okay? So the stretch reflex is classified as spinal, somatic, monosynaptic, ipsilateral, and innate, right? So you can see what it looks like here. That's the stretch reflex, okay? And what's the purpose of it? To make sure the muscle doesn't tear, okay? If the muscle gets overly stretched, it will tear, and it won't heal, all right? So this keeps that from happening. The Golgi tendon reflex is the flip side of this. It prevents muscles from contracting too much, okay? Because if they contract too much, what can you do? You can rupture the tendon, okay? So the Golgi tendon organs detect excessive tension. They're proprioceptors that are in the muscle tendon junction. Their sensory axons excite interneurons in the spinal cord. The interneurons inhibit motor neurons of the same muscle, and the muscle relaxes and prevents it from getting damaged, okay? Some excited interneurons excite motor neurons of the antagonist, and the antagonist will contract, and that is a polysynaptic reflex, okay? So there's Golgi tendon reflex, right? We've got afferent information, right? If we contract the muscle too tight, the tendon's going to tear, right? So we send that information from the Golgi tendon organ past the dorsal root ganglion into the dorsal root, and then interneurons are going to carry outgoing information both to the quads and the hammies, all right? And what's going to happen is that the hamstrings are going to contract, okay? And the quadriceps are going to relax, all right? And that keeps the tendon from tearing off its connection to the bone, okay? The withdrawal reflex is to pull the affected limb away from a painful stimulus. So what happens is that we've got a portion of the reflex arc that's on the same side and a portion that's on the opposite side called the crossed extensor, all right? The simple withdrawal reflex is ipsilateral, all right? So there's a painful stimulus that moves from the affected limb to the spinal cord, then an efferent comes out of the spinal cord and talks to muscles that are going to withdraw the limb from the painful stimulus, okay? And they also are going to inhibit neurons of the antagonistic muscle. In the crossed extensor reflex, we combined the withdrawal reflex with pushing away from the painful stimulus with the opposite limb, okay? An example of this is you're walking on the beach barefoot and you step on some broken glass. The foot that steps on the glass will bend, go up away from the pain. The other leg will go bolt straight, pushing away from the painful stimulus, okay? If that didn't happen, you'd fall over. So this happens along with the withdrawal reflex. Some interneurons are excited by the nociceptor, the pain stimulus. They cross midline and excite extensor muscles on the other side, such as when the left leg is withdrawn, the right leg's quadriceps are going to flex. Your leg will go bolt straight. That'll support your body weight, and you'll withdraw from the painful stimulus. It works in the upper arms too, right? If we did a test where we applied a painful stimulus to your right hand, okay, you would push away with your left hand, all right? I could demonstrate this to you if you're curious about it in lab. If you want to do some reflex tests, that's some of what you'll do in the last set of labs that you submit for this class. And those are things you can do at home if you can find the supplies, okay? Reflexes are important to check the integrity of the spinal cord, okay? So they can test for the function of specific muscles, nerves, and spinal segments. A hypoactive reflex is diminished or absent and indicates either damage to the cord or to the muscle or to the junction between the nerve and the muscle. So let's say we're trying to do a withdrawal reflex, right? Like your finger touches a painful stimulus, you're supposed to pull your finger away, right? And if you don't, then we might have damage to the muscles that control the withdrawal of the wrist, okay? We might have clipped some nerves talking to those muscles, or we might have damaged the region of the spinal cord where either that sensory information goes in or that motor information comes out, okay? In a hyperactive reflex, we get an abnormally strong response that can indicate damage to what we call the upper motor neurons, right? So that's the connection between the brain and the peripheral nerves, okay? If we see something called clonus, which are rhythmic oscillating movements that occur with reflex testing, then that can indicate something like, say, a stroke in that part of the brain, which would be part of the circuitry of the upper motor neurons, okay? Now, we talked a little bit about where the nervous system comes from, right? You start out as a single fertilized cell, right? That's called a zygote. That's where the sperm fertilizes the egg and forms a new diploid cell, and that begins to divide very rapidly and form a ball of cells called a morula, and that will eventually form a hollow ball of cells called a blastocyst. And inside that blastocyst will be something called an inner cell mass. And that's eventually going to be you, okay? That blastocyst will implant into the endometrium of the uterus and then will begin to develop through the process of growth, morphogenetic movement, and differentiation, okay? Growth is just increase in size. Morphogenetic movement is the movement of populations of cells from one location to another, okay? And differentiation is the change in characteristic of those cells from one particular appearance and behavior to the appearance and behavior it's going to have in the adult organism, okay? And also, we should say, cell division is part of this as well. Well, at some point after the blastocyst plants, the cells that are going to become you are going to be contained in a disc, a disc of cells between the yolk sac and the amniotic sac. Okay, the yolk sac contains nutrients to allow the embryo to develop, but in mammals it's pretty small because we have internal fertilization and development, whereas in something like a chicken, it's big because they have to develop outside the mom, so they need all their nutrients with them to get that done. And the amniotic sac is eventually going to enclose the embryo and the fetus like a protective sac of fluid that allows it to move and prevents adhesions, which are attachments of the embryo or the fetus to itself that aren't supposed to be there. Okay? It also serves as a reservoir for the production of fetal urine later on. But at one point, you're a disc between those two sacs, okay? And what will happen is that a structure, well, the disc will become a three-layered disc, okay? Something called a primitive streak will develop down the middle of the disc. And then through that primitive streak will migrate a population of cells that will basically accumulate on top of the yolk sac, and they're going to become what's called the endoderm. And then a second population of cells will move through the primitive streak and become a population of cells known as the mesoderm. Okay? The ectoderm forms the epithelial tissue and the nervous system. The endoderm forms the lining of the reproductive, urinary, and digestive tract and respiratory tract. Okay, and the mesoderm forms everything else. Right. So what happens after the primitive streak forms is that a structure called a notochord will develop. That's a mesoderm rod that runs under the primitive streak, and it's going to cause something called the neural groove to form. Okay, which is sort of a divot down the middle of where the primitive streak was. Okay, and that neural groove will then eventually drop below the ectodermal layer and close from the middle of the disc towards the head and from the middle of the disc towards the tail where your legs would be. All right. And once that happens, we have something called the neural canal. Okay. And that becomes the central canal of the spinal cord, and the spinal cord around it is what's formed from the closure of the neural tube. Okay. What will happen next is that you'll have the formation of the brainstem, and then finally the brain itself, the cerebral cortex. Okay. By the 6th week of embryonic development, the sulcus limitans generates a horizontal groove in the lateral walls of the canal, and that represents the dividing point between the basal and the alar plates. Okay. The basal plates are structures in front of the sulcus limitans, so those develop into the anterior and lateral horns and the anterior gray commissure, and the alar plates, alar means wings, develop into structures posterior to the sulcus, which are the posterior horns and the posterior gray commissure. And then during the fetal period, growth of the vertebral column is going to outpace the growth of the spinal cord, and that's why our spinal cord ends up terminating at L2 instead of going all the way down to the bottom of the lumbar spine. All right. So this is a look. See, you start out as a disc, and then you start to roll up. Okay. You're rolling up from lateral to medial here. This is the neural tube that was once the neural groove. You can still see some neural groove here and here, right? Neural tube is dropping below that groove, right? And that's going to be your central canal, and the rest of this is going to be the spinal cord, right? And then you've got the development of the different ganglia, right? And the different pieces of gray matter, okay? So the first thing to form is the spinal cord. The next thing to form is the brainstem, and the last thing to form is the cerebral cortex. And that's the same thing that happened in evolution. Okay? If you look at a primitive nervous system, what you see is a progression from basically just a spinal cord and some ganglia near the head to a spinal cord and a brainstem to finally a spinal cord, a brainstem, and a cerebral cortex. So biologists call that ontogeny recapitulating phylogeny, which is a way of saying that the events of development seem to reproduce the events of evolution. So the theory goes that the memory of evolution is contained in our genes and gets replayed every time we make a new organism, okay, from primitive to more advanced, okay? All right, that covers 14, and that's all